Good day everyone, I'm John, moderator for this webinar. I welcome everyone for today's webinar, Improve Documentation in Pain Management. I would now like to introduce our presenter for today, Stephanie Thomas. Stephanie Thomas, CPC, CAMPC, has over 20 years in the medical billing world. She owns a billing, coding, and consulting company and serves private practices across the US. Early in her career, she spent 9 years in a clinic setting where she was not only working in billing but also front desk management. Her specialties are family practice, urgent care, anesthesia and pain management, orthopedics, physical therapy, chiropractic, and mental health. It was a great having you with us. Over to you, Steph.
Thank you so much. Welcome, everybody. So glad to be here today. I'm excited to talk about pain management. It's one of my favorite specialties that I work in for sure. Been doing it for a long time. So let's go ahead and get started. There's a lot to cover today. So let's go over what we're going to talk about today. So obviously documentation is why we're here. But we're going to start with talking about the patient visit. Where our documentation and our patient visits comes in handy is when we try to go and have our procedures done, we need to make sure that our documentation is sufficient for pre-authorization purposes and obviously medical necessity for any kind of procedure that we're doing, even if there is no pre-authorization needed. We're also going to talk about coding for pain management and the level 3, 4s, and 5s. So let's dive right into evaluation and management. So again, starting at that first initial visit, the history and why this patient is here. So it's very important that we get an extensive history, especially in pain management, because a lot of these patients, the pain that they're having is not something that just started yesterday. This is something that's been going on for quite a while, and they've probably had other treatments, or they've seen other physicians, or maybe they've just been suffering with it for a long time, but likely they've been doing things for it that have either helped, or maybe it helps for a while, but it's not helping anymore. But all of that information is solid gold for us, and we need to get that information onto our chart system. So all of that information is super, super important that we need to make sure it gets into that chart note. One thing that I've really seen coming in this year especially is with the pain management authorizations. A lot of them are asking us for dates and locations and how long the patients have been treating for chiropractic, physical therapy, things like that. Even if they have tried acupuncture, things like that, they're wanting to know when they did that, how long they did that, and what their, pain relief was, even if it was only pain relief for a short amount of time. So we really need to have the details of all of that information. It may not seem important to the medical assistant at the time, but if we help educate them, then that will really help with, billing and the pre-authorization and the medical necessity, all of that down the road with this patient's care. So moving on to our own, pain management procedures. So all of these procedures are, of course, things that we see every day, right? These are things that we are used to doing. We're used to seeing the same documentation for pretty much these procedures over and over and over. But what we need to remember is that every insurance is different, and these policies are changing all the time. Moving on to our radiofrequency ablations, all the same things of that previous slide are the same, obviously, because we've already done those medial branch blocks. So we're moving on to the radiofrequency ablation. And then additionally, we need to have the results of those dual diagnostic blocks. Most insurances are going to require those dual diagnostic blocks. Very few that I have even heard of will allow just a single block. I think it's a good idea to always do the dual diagnostic blocks. According to the pain societies that I am in contact with, they all recommend the dual blocks. Also, very good idea, and most of the Medicare carriers require pain scores or functional improvements be documented after those dual or after the diagnostic blocks. So make sure that is in the documentation. And it could be as specific as what time those pain scores were obtained and how long the functional improvement lasted, things like that. So it's not just like pain score is this today. It needs to be more information. We do have some changes to our prolonged services, which I'm super excited for in 2023. So these are available to use in 2023. So don't use these until then. But we have a new code, 99415, that is a prolonged service with staff for the first hour. So this is to be used with your E&M code, and this is just for staff time, and it starts at 29 minutes. So if your staff was with a patient for more than 29 minutes without the doctor, then you can bill 99202. 29 minutes is the value of the code. So after 59 minutes, then you can bill a 99415. Here are the links to the top payers' website and their policies. Again, during this broadcast, I did give you the guidelines that I am most familiar with, but I do encourage you to go out to these websites often and get the updated policies. They are updated at least yearly, if not more frequently. The bottom link here is for the Medicare coverage database. That will include both your national coverage determinations as well as your local coverage determinations for your local Medicare map. We're going to talk about auditing for a little bit. So I know we talked about auditing a little earlier when we were talking about the sets and RF, but auditing is super duper important. When we are doing billing for pain management, a lot of times we get into habit. I am not perfect. Nobody is perfect. Everybody gets into the habits of, oh, well, this is the covered diagnosis code for this procedure. And so they just get in the habit of selecting that, or the provider gets in the habit of just selecting that, but then the documentation says something totally different. So it's extremely important that you have things in place within your own offices, within your own billing team, within your own billing company, whatever your situation is, that we are auditing things often. It's important to audit before things happen. Don't audit after you got audited by a insurance company. Audited after you had a problem with a denied claim. Audit early and audit often.
Oh, that was a wonderful webinar.
I hope everybody enjoyed the webinar. Thanks so much, and I hope everyone has a great rest of your day.